Good morning, everyone. This is Dr. Nagraj here from IIP Digital Media Team. This webinar is conducted by Utkal IIP and IIP Women's Cell Branch on the eve of International Women's Day and webinar on empowering women and restoring physiotherapy's role in breast cancer rehabilitation. So, without wasting time, I'll be sharing the all the links of the IIP Digital Media Team. Please do follow for the more updates on the like these webinars. And I would like to hand over the session to Dr. Rituma. Ma'am, over to you.
Yeah, Priya ma'am, can you please proceed since we are not able to hear Nagraj sir?
Hello, ma'am. Can you hear me? You can start the session.
Yes, sir.
Ma'am,
Priya ma'am or Ritu ma'am, please give an introduction of yourself and ma'am, and please
Okay,
proceed.
ma'am. Okay, ma'am. I'm starting the session now.
Thank you.
Mhm. Oh. Good morning, everyone. Thank you for joining us today for this exciting webinar. We are thrilled to have you all with us as we dive into the topic empowering women and restoring lives, physiotherapy's role in the breast cancer rehabilitation. I, Dr. Rituparna Mahanti, Sub-Coordinator IAP Women's Cell, Utkala Branch, Odisha, and I will be a moderator for this session. Our expert speaker is ready to share her insights, and we are thrilled to have her with us. Now, without further ado, let's get started. I'm excited to introduce our speaker, Dr. Vandana Patel, who is a highly accomplished physiotherapy and rehabilitation professional with over 16 years of clinical experience and 7 years in academia. She holds a master's degree in rehabilitation from the prestigious Swami Vivekananda National Institute of Rehabilitation Training and Research, Cuttack, Odisha, and also did fellowship in onco rehabilitation from Gujarat. She is currently pursuing PhD from Waikaka University, Gujarat. Dr. Vandana is a certified lymphedema therapist from Tata Memorial Hospital, Mumbai, a certified palliative care therapist from Trivandrum Institute of Palliative Sciences, Kerala, and a certified women's health practitioner from Gujarat. As an assistant professor at Government Physiotherapy College, Raipur, and Rehabilitation, in charge at the Regional Cancer Center, PT, JNM Medical College, Raipur, she plays a vital role in cancer rehabilitation. She is deeply involved in research and patient care, focusing on oncology rehabilitation, geriatric physiotherapy, and lymphedema management. Dr. Patel is a prolific researcher and speaker with multiple paper presentations at many national conferences. Her contributions to physiotherapy literature have been published in prestigious journals, and she has authored a chapter on the rehabilitation of breast cancer, which has been published in renowned medical textbook. As a recognized expert in the field, Dr. Patel has been appointed as a master trainer by the government of Chhattisgarh to train state physiotherapists in geriatric rehabilitation and leprosy rehabilitation under the National Leprosy Eradication Program, Government of India. An accomplished author, she has written the acclaimed book Geriatric Principles and Physiotherapy, a comprehensive guide to the unique rehabilitation needs of the elderly. She continues to be a sought after speaker known for her engaging presentations and commitment to advancing physiotherapy education and practice. We welcome you, ma'am. We encourage all the participants to engage with us throughout the session. Feel free to use the chat or question and answer feature to ask any questions you have. E-certificates will be provided only to those who are present in the session and fill the feedback form. Ma'am, you can proceed now with your presentation.
Thank you so much, ma'am, for that warm welcome. Before starting my session, I would like to thank IAP and IAPWC Utkal branch for having me to speak on a topic breast cancer, which is the most common problem nowadays. Every woman, not only in the latest stage of their life, but also in the early phase of their life, they are suffering. So before that, I am also here to wish all the esteemed women present over here a very happy Women's Day. So let's start with the session now. Is the PPT visible?
Yes, ma'am, it is visible.
Yeah, thank you so much.
Thank
So
you.
we know that breast cancer is the most common cancer globally, and it is the first most common cancer that is responsible for death among the females. If we talk about the data of Globocan in 2020, they have reported that approximately 2.3 million new cases of breast cancer are estimated to emerge annually, and WHO reported that cancer alone is responsible for causing 107.8 million disability adjusted life years. Out of this, breast cancer alone is responsible for causing 19.6 disability adjusted life years. So there are many factors which are responsible for causing breast cancer. Some of the factors are modifiable and some are non-modifiable. So the non-modifiable factors are like the gender. Uh, Breast cancer can occur in males also and females also. However, it is more common. We know that females are generally affected with the condition. If we talk about the age, all these are the non-modifiable factors. If we talk about the age, then we can see that breast cancer is more common at the age group above 50 years of age. However, nowadays, because of the lifestyle disorders, it has now become common during the early stage of life also, like the young women before marriage only, they are affecting with the condition. In the family history, if we talk about it is cancer is generally related to the genetic factors. So if there is any history of cancer in your family, that the person are at risk of developing the cancer. Genetic mutations are usually seen in the DNA, like the BRCA1 and BRCA2 markers are there, which is responsible for the breast cancer. And during the gene study only, these markers are only seen in order to predict whether the person are at risk of developing the cancer or not. Then the menstrual and the reproductive history usually seen after 50 years, that means during the menopausal phase. However, it is not like that. The actually breast cancer is having a strong association for your estrogen hormone. So whenever there is more of the like the if the female is having a early menarche, or if there is a late menopause, that means the estrogen level will be high in that female. That is, the female is exposed to the estrogen for a longer duration of her life. So because of the exposure of estrogen, longer exposure of estrogen, the female will always be at risk of developing the breast cancer. And then the breast density, it has been seen that the females with dense breast or heavy breast, they are more prone to develop the cancer. And the logic behind this, or the reason is because of the dense fibrous tissues which are present in the breast. And then the modifiable factors, which are the physical inactivity, more the sedentary life, more will be the risk of developing cancer, obesity, alcohol and smoking consumption. That's the reason why the females of the Western countries are more prone to develop the breast cancer as compared to the Indian females. And then the diet and chemical exposure, again the same. It has been seen that the females of the American states are more they are having more cases of breast cancer there as compared to the Asian countries, because of the like they used to consume more of the canned food. So because of all the dietary factors, these women of the American countries or the Western countries, they are prone to develop the breast cancer. So if we talk about the etiology, whenever there is damage in the DNA or any kind of genetic changes are present, like the abnormal genes like the BRCA1 or BRCA2 is present, then the patient is at risk of developing the cancer, and this gets triggered by the presence of estrogen. I have already told, more the exposure of estrogen, more will be the chance of developing the breast cancer. So if we talk about the classification, breast cancer, normally breast cancer or any cancer is of two types. It is either invasive in nature or it is non-invasive in nature. Like for example, if we talk about the breast cancer, it is in situ carcinoma. In situ carcinoma means the cancer is encapsulated. It has not been spread to the adjacent tissues. And so it is not invasive in nature. For example, the ductal carcinoma in situ and the lobular carcinoma in situ. In the diagram, you can see that this is the normal breast, and these are the ducts, milk ducts, and they open into the lobules. So what happens if these ducts, they are affected? So there will be changes in the epithelial lining of the ducts, and there will be some kind of changes in the cells, and that will lead to the tumor formation there, which is known as the in situ ductal carcinoma, because the tumor is inside the capsule. That is, it has not broken the wall, the epithelial wall, and it has not invaded the adjacent structures. So it is the ductal carcinoma in situ. And similarly, the lobular carcinoma in situ means, again, the cancer is in the lobules and it has not invaded to the adjacent structures. When we talk about the invasive carcinoma, then from the name itself, it is clear that it is invasive, it is destructive in nature, means now it has broken the capsule or the epithelial wall, and it has now reached to the adjacent structures, and it has now become invasive in the sense, if proper treatment is not being taken at this stage, then it would lead to the next stage or the last stage of the cancer, and that would finally lead to the death of a person. So if the cancer is invasive, prompt treatment has to be instituted. See, it is always said that precaution is always better than care. So a woman should inspect her breast every month. Now you must be wondering, like, at what time or in what particular date we should check the breast. So it is usually recommended that a female should check the breast 6 to 7 days after the after the periods. So because what happens, you must be knowing that before starting of the periods, most of the females, they have tenderness over the breast, and this is normal. This is under the influence of your sex hormone. So once the periods gets over, the female has to check or inspect the breast after about 6 to 7 days. So you can just stand in front of the mirror naked, and then just lift both the hands overhead and look for any kind of changes in the size of the breast or in the level of the nipple. Whether both the breasts are of same size, or is there any changes in the nipple, or whether the one nipple is up and the other is down, or the nipple is retracted. So you need to check for any kind of changes in the nipples. Now, it is not like we all know that both the breasts, they are not of same size. One breast is always bigger than the other. So it is not like that because there is a discrepancy in the size of the breast, so I'll be having the breast cancer. It is not like. You have to check for other signs also. Like, is there any kind of changes in the areola? the skin around the nipples or over the areola, they become dry, scaly, and there might be any kind of discharge from the nipple. This discharge could be anything. Either it could be a serous discharge or a blood discharge. So it could be anything. Then you need to look for the all the quadrants. You have to feel all the quadrants of the breast with the tips of the finger. Just move your finger in a circular manner around the nipples over the breast, and look for or observe for any kind of lump you are feeling over the area. Start from the medial side, upper quadrant, then move gradually to the lateral side, and then along the lateral aspect downwards, and then finally the middle side of the breast. So this way you have to check for the presence of any kind of lump, and then check for the presence of the axillary lymph nodes, because axillary, if there is cancer, the lymph nodes will going to get enlarged. So you will going to feel the lymph nodes also if there is any cancer present over there. And then make yourself lie in the bed, and then keep your hands overhead and look for the inferior part of the breast, palpate for the in the inferior part of the breast, and see whether any kind of lump is there, and look whether the lump is movable or it is adherent. Usually movable lumps are also there, like in case of adenomas, they are usually mobile, but in case of cancer, the lump is hard and they are usually adherent to the underlying structures. So it is very essential for all the females to go for self-examination of the breast in order to detect early presence of the breast cancer, so that early and prompt treatment can be started. Then we'll discuss about the clinical features of the breast cancer. There may be palpable lump in the breast. This lump could be tender or it may not be tender. There will be a nipple discharge. It could be anything, a serous discharge or the blood discharge. You will be able to see the changes in the breast skin or in the shape of the breast. And then finally, the enlarged lymph nodes that you will going to feel in your axilla. If we talk about the investigations, we know that biopsy is the first line investigation, which is usually performed by the oncologist if they suspect any kind of cancer or cancerous lump in the area. So it is not like if only lump is present, then you should go for the biopsy. But even if lump is not there, or you are not able to detect any kind of lump over your breast area, but you have seen the changes in your nipple or in the areolar area, that means the biopsy is needed to confirm whether the changes that has occurred in the skin or the areola or the nipple area, it is due to the cancer or it is not due to the cancer. So biopsy has to be performed if any kind of changes are seen in absence of lump also. Then the fine needle aspiration cytology is usually indicated in case where there is cyst. So if a cystic lump is there, then during insertion of the needle, the cyst will going to burst and the swelling will going to subside. This can be then confirmed by doing the mammogram. So if only cyst is there, then it will going to subside. But if cancerous lump is there, then even after FNAC, the lump will not going to subside. It will be there, and further investigations needs to be done in order to investigate the cancer. Imagine, that mammogram is done for all the cancer patients. It is actually done for seeing the deformation of the tissues, and also the microcalcifications that occurs in almost all the patients. So this is something which is a clinical indicator, you can say, for the presence of malignancy in the body. So if it is there, if microcalcifications are there or deformation of tissues are evident in the mammogram, that means it could be a malignancy. And then ultrasound is usually done in patients with heavy breast, where the lump, it becomes difficult to detect the lump through the manual palpation method. So in that case, ultrasound is a good choice of investigations, and MRI is done to actually localize the actual location of the lump. Certain molecular markers nowadays, it is mandatory for all the breast cancer to go for the molecular studies like the ER, PR, and HER2. This is the estrogen progesterone receptors and the human epidermal receptors. These are what happens, as I have already told, that breast cancer has great efficacy for the estrogen and the progesterone. More the estrogen, more will be the tendency to develop the breast cancer. Or if the breast cancer is already there, then it will have a tendency to flare up or to change into your malignancy, your invasive type. So during the ER or the PR study, we see for the presence of these receptors, and these receptors, if it is present, that means the patient is ER/PR positive. Then they become the candidate for your hormonal therapy along with the chemotherapy. So chemotherapy is a choice of drugs which is given for all the cancers, right? But hormonal therapy is only given to those patients who are hormone receptors positive. And HER2 positive means, HER2 means the human epidermal receptors. This means if it is positive, then the patient has to take additional drugs, that is the target chemotherapy. So along with the normal conventional chemotherapy, the patient will be given the hormonal therapy. Normally tamoxifen is a choice of drugs which is given in hormonal therapy, and also the target therapy if they are ER, PR, HER2 positive. That means triple positive. A case of CA breast triple positive we used to write in the prescription. And next is the triple negative. Triple negative means ER negative, PR negative, and HER2 negative. These candidates are only and only will respond to the chemotherapy, and they are usually having poor prognosis. But the triple positive patients, they have good prognosis. Then comes the additional tests like the normal chest x-rays, routine blood investigations are done, chest x-rays done in order to see any kind of metastasis in the lungs. And then the abdominal scan, bone scan is again seen to check for the presence of any kind of tumor or metastasis in your liver and in the bone, because CA breast, they have the tendency to spread to your brain, lungs, liver, and bone. So now we'll be discussing about the stages of breast cancer. So again, there are 5 stages of breast cancer. Stage 0 is non-invasive, means in situ, presence of cancer in situ, which we have seen the ductal carcinoma in situ or the lobular carcinoma in situ. So it is non-invasive in nature. It has not, it will not going to spread. It is not having any destructive nature. It is encapsulated. So it is the earliest stage of cancer. Then comes the stage 1. Now you will be able to locate the lump, and the lump will be less than 2 centimeter in size with no involvement of lymph nodes in stage 1A. And in stage 1B, tiny cancer cells will be there and lymph nodes will be involved. In stage 2, again, it is divided in 2 subsections like the stage 2A and stage 2B, depending upon the involvement of the lymph nodes. So that when the tumor size is less than 5 centimeter, it is stage 2A with involvement of 1 to 3 lymph nodes. And when the tumor size is more than 5 centimeter with involvement of lymph nodes, but it has not metastasized to the distant areas, then it is the case of stage 2B. In stage 3, there is more number of lymph nodes which going to get involved. So in stage 3A, 4 to 9 lymph nodes will be going to involve. Then in stage 3C, more than 10 lymph nodes will going to get affected. In stage 4, that is the metastatic stage. This is the last stage of the breast cancer, where you are going to see the spread of the cancer either in the brain or the lungs, bones, or the liver. So when the patient approaches to the oncologist, then TNM classification is done. TNM means the presence of tumor, then the nodes and the metastasis. This is TNM. So on the basis of TNM classification, staging of cancer is done. And if the patient approaches to the doctor in the right time, that is during the early stage of the cancer, then the patient is having a good prognosis. And when the patient approaches at the last stage of the cancer, then because of the metastasis, because of the distant metastasis, the patient has now become a client for the palliative management. So only the palliative symptomatic relief will be given. No kind of chemotherapy or radiotherapy works here. However, in case of metastasis to brain, radiotherapy is usually opted by the oncologist just to minimize the symptoms or the effect of any kind of mass effect on the brain. So again, we know that why we need to study all these things like the surgery about radiation and chemo, because we are going to see the patients of cancer during our rehab program. And there are certain drugs, chemotherapy drugs, which causes neuropathy, which have effect on the muscles, on the bones. So we need to know the what type of drugs the patient has taken during the chemotherapy, or what type of drug is the patient is taking at present when she has approached to you. So surgery, there are two types of surgeries which are recommended for the breast cancer. These are the conservative surgeries of breast and the non-conservative surgeries of breast. So when we talk about conservative surgeries, it is clear from the name itself that the breast will going to remain there. The breast will not going to get removed. So in this, the femininity of the female, it remains, and there is no negative body image of the in the person. What happens after the surgery? Most females, they goes into depression or the anxiety because of the negative body image which they develop. They always see like something is missing from my body. I have lost my feminism. So most of the times, if the lump is small or if the female is not married, so doctors used to advise them that you can opt for the breast conservative surgery, but this is not the case always. If it is a metastatic invasive surgery, then it is always better to remove the breast. So in breast conservative surgery, simple lumpectomy is done. That is, the surgeon will going to remove the lump. A wide local excision is done along with the removal of your lymph nodes. Lymph nodes means not all the lymph nodes of the axilla is removed, but only the sentinel lymph nodes is removed. Sentinel lymph nodes means the first lymph node that going to get involved due to the cancer. So they're going to remove the sentinel lymph nodes, that is where the cancer has spread, along with the lung. In the non-breast conservative surgeries, there are mastectomy, which is again simple mastectomy and radical mastectomy. So when we talk about the simple mastectomy, it is the whole breast is removed along with the lymph nodes. But the pectoral muscle, they remain intact in this condition, and also the skin and the nipple over the breast remains intact. So in simple mastectomy, skin and the pectoral muscle, they remains intact. Only the removal of the breast tissues as well as the lymph nodes, the sentinel lymph nodes, they are removed. So simple mastectomy is a choice of treatment when the patient wants to have a reconstructive surgery or wants to have a implant done. So what happens during the reconstructive surgeries? If skin is not intact, if ample amount of skin is not there, then in that case, the surgeon takes the graft either from your thigh or from the abdomen or from the back, and they transfer the graft on the over the breast to give the shape of the breast there. But in case if the skin is intact, then in that case, what happens after the simple mastectomy, expander is left in the surgical site. This expander helps to expand or to lengthen the skin over that part. So it is usually kept for about 3 to 4 months. Once the proper or the ample length of the skin is achieved, then after that, the expander is removed and the silicone breast implant is instituted in the place and the surgery is performed. So, simple mastectomy is a choice of treatment or choice of surgery if the patient wants to have a cosmetic effect or the reconstruction done. Nowadays, a common surgery which is being performed is the radical mastectomy, that is the modified radical mastectomy. Earlier, what happens during the removal of the breast, along with the breast lymph nodes, the surgeon used to remove the pectoral muscles also. Because of removal of the pectoral muscles, the disability has got higher in these patients, and the quality of life of these patients were very poor. So it was then modified, and it was decided that surgery has to be done only that removal of the breast tissues along with the lymph nodes needs to be done, but pectoral muscles should not be removed so that the patient's quality of life will not get hampered and she can lead a good quality life in her lifetime. Next is the radiation therapy. Radiation therapy is mandatory for all the candidates of the breast conservative surgeries. That means those patients who have opted for lumpectomy, they should go for the radiotherapy. And radiotherapy is not mandatory for the MRM patients, means the modified radical mastectomy patients. It is not needed that radiotherapy has to be done. However, it depends on the choice of your oncologist. If it is invasive in nature, if it is associated with metastasis, or if it is associated with the involvement of lymph nodes, then after MRM, radiation therapy is required. But if it is not associated with the lymph node involvement or any kind of metastasis, invasive nature, then only the surgery along with the chemotherapy is done. In that case, radiation is not needed. Also, radiation therapy is given to patients who have landed in the palliative phase of their life. That is during the last stage, during the metastasis, particularly metastasis to the brain. In that case, patients has to take the radiation therapy so that the effect of the cancer could minimize and the patient symptoms could be relieved, and we can improve the quality of life of that patient. वो जब तक जिंदा रहे तब तक के. Then comes the chemotherapy. Chemotherapy is given, it can be given before the surgery or it can be given after the surgery depending on the stage of the cancer. Like for example, if it is given before the surgery, it is known as the neoadjuvant chemotherapy. The main aim of giving the neoadjuvant chemotherapy is that the size of the cancer gets regressed and the surgeon is having a clear, more visuality of the area. And suppose if 6 cycles of chemotherapy has to be given to a particular female, then the doctor will going to decide that 2 cycles will be instituted prior to the surgery. This will going to regress the size of the cancer, and then surgery is done, and The remaining 4 cycles will be instituted after the surgery. Then comes the hormone. And yes, I want to tell you that chemotherapy is having an ill effect. Like most of the chemotherapy, they are responsible for neuropathy. That is known as the chemotherapy-induced neuropathy. Fatigue is also there. Chemotherapy-induced fatigue is present in the cancer patients. So we should have a sufficient knowledge about the chemotherapy drugs also. Like what are chemotherapy drugs the patient has taken whenever she approaches to you for the physiotherapy, so that you can plan your treatment in a much better way. And then comes the hormone therapy. As I've already discussed, that hormonal therapy is given only to the patients who are PR positive patients. And the tamoxifen is a drug which is usually given to these patients. However, it is associated with the ill effect, that is, it is responsible for causing your osteoporosis. It has the tendency of bone resorption. So whenever hormonal therapy is instituted to the patient, along with that, the doctors always give calcium supplements also to these patients. And along with that, they prescribe physiotherapy also. So here we need to give the strength training to these patients along with the other weight bearing exercises, so that we can promote the osteogenesis and we can help the patient to of the osteoporosis patients. And then the targeted therapy is given in the patients who are HER2 positive, HER2 positive. These are the hormonal receptors which we see during the investigations, and target therapy is usually indicated in post-menopausal females. Along with these, many doctors, they advise the patients to remove the ovaries also, like the oophorectomy is being done. And however, consent needs to be taken while doing these procedures, because if the female is at the childbearing age, then consent needs to be taken. The surgeons have to explain everything, what all consequences will be there if the ovaries are not being removed. So the main aim of removing the ovaries in CA breast patients or suppressing the function of the ovaries in these patients is to reduce the production of estrogen, so that estrogen production gets reduced, and the patient will not going to expose to a prolonged or large amount of estrogen in the body, and the breast cancer tissues will not going to proliferate, and there will be not the cancer will not going to reverse, or recurrence will not be there. So many a times patients opt for going for the removal of ovaries also, but consent has to be taken. Without consent, this surgery should not be performed, especially in younger females. Then what are complications which are associated with cancer treatment? It can be divided into 3 stages: complications due to surgeries, due to chemotherapy or hormonal therapy, and due to radiotherapy. Always remember that the role of physiotherapy, oncophysiotherapist, is from the first day, that is the day when the cancer has been diagnosed, to the last stage of a life of that particular patient. That means from the prehabilitation to the palliative phase of a female, we are having an important role. We are there to improve the quality of life of these patients. So during surgery, what complications the female have? There may be infection at the site, there may be pain, post-mastectomy pain will be there, sometimes phantom breast, like the phantom limb, phantom breast sensation is there. The patient still feels the presence of breast in the body, though it is not there, but she feels it, and she complains of tingling sensation, pain over there. So here it is our responsibility to look after the condition. Then the patient will complain of back pain, particularly if the graft is being taken from your abdomen. This is the reason why pre-operative physiotherapy is important, because if we know after the discussion with the oncosurgeons, if we know that the patient will going to get reconstructive surgery done, and the graft will be taken from the abdominal muscles, then it is a responsible to strengthen that muscle so that after the surgery, the power will going to reduce, and if the power is already less preoperatively and we have not seen or we have ignored the condition and no strengthening exercise has been taught to the patient, then after the surgery, what problem the patient will going to have is the back pain, because your core has now very less in power and it is not properly bracing the power. So there may be alteration of posture also, like for example, there is surgery being done on the chest. So the patient always has a tendency to sit in the stoop posture. This is very wrong practice, because the patient will going to develop tightness over the pectoral muscles. So from the day one itself, we have to look for the posture, and during the preoperative physiotherapy also, postural education has to be given to the patients. Lymphedema, most common complication and most underrated and underdiagnosed complication of these patients. Lymphedema can develop at any phase of life, after the surgery also, and decades after, 10 years, 20 years also in these patients. So lymphedema precautions has to be given in these patients. Cosmetic issues will always be there. There will be sometimes what happens, the surgical side, it becomes very much hard, it gets adherent, and folds, skin folds develops. In these skin folds, bacterial growth or fungal growth may also develop. So these type of problems will be there. Because of infection, patient will also develop pain over that area. And the last is the axillary web syndrome, axillary cording. This is what happens during the surgery or after the radiotherapy, fibrosis of the structures occurs. So when radiation is given, it not only kills the cancerous cell there, but it also kills the other healthy tissues present over that area. So in axillary cording, whenever the patient tries to do any kind of overhead activity, then in this area, at the axilla, you will going to feel for the cord-like structure. There will be cord-like structure that can be felt with palpation, or sometimes it is so hard that it is evident. Like whenever we ask the patient to lift the hand, we will able to see the cord-like structure that is going to get pop up in this area. So this structure is because of the fibrosis of the tissues, and sometimes it causes radiating pain up to the elbow. And most of the time, these patients, they remain neglected, because the patient complains of elbow pain, we started giving treatment around the elbows, thinking of tennis elbow or any other conditions around the elbow, or the cervical origin, pain of cervical origin, but we never go for the inspection of the axillary area to look out for the axillary cording. So it is a good practice. Just ask the patient to do the overhead abduction and look for any kind of visible cord-like structure or palpable structure there. Complications due to the chemotherapy and hormonal therapy, nausea, vomiting, and diarrhea are most common, and this actually have an effect on the quality of life of a patient, and the patient denies to participate in the physiotherapy program because of all these conditions. So another is the loss of hair, alopecia. Loss of hair is because of the side effects of the chemotherapy, and it can be prevented or it can be controlled by using your cooling caps. A specialized type of machines are there, which are available in good higher centers, cancer centers, where a cap is there. A machine is there. In that, a helmet type structure is there, which has to be worn by the patient, and that structure gives a cooling effect on the head of the patient. Because of the cooling effect of the cooling caps, the blood supply to the hair follicles, they gets reduced. It causes vasoconstriction there. And so the amount of chemotherapy drugs that passes to the, or that reaches to the follicles, hair follicles, that gets reduced. And as a result, the side effect at the level of hair roots, it gets minimized, and the hair loss also gets minimized. It is usually given 30 minutes prior to the institution of chemotherapy and also after the chemotherapy for about 1.5 to 3 hours. Chemo brain is another problem which our patients suffers, that is the temporary loss of memory during the chemotherapy. This is known as chemotherapy brain. And here the cognitive behavioral therapy plays a very important role, and also our psychologists in the centers, they deal with these conditions. Patient may have dryness at the vagina, and so the patients again will complain of pain over that area during any kind of sexual activities. And most of the time, this oncologists, they refer these patients to us to look into the matter. So we have to see what is the actual cause of dryness of vagina. It is actually due to the drugs which is instituted, and it gets subsided once the regime of the chemotherapy is over. However, if it is more troublesome for the patients, then we can ask the oncologist to prescribe certain type of gels, which are the hyaluronic acid based gels that helps to retain the wetness over the area. Then the neuropathy, which is very common, and we used to see these type of patients a lot during our clinical practice. Most of the patients, they come to us with a complaint of pain, tingling, and numbness over the either on the feet or on in the hands, and sometimes it is so profound that the patient also develops radiating pain from the brachial plexus. So in these cases, we have to take strict action, and physiotherapy has to be instituted. Otherwise, if we're not going to give any kind of treatment in these type of patients, then gradual weakness of the muscles will going to develop, and many a times the patient will also come with the complaint of foot drop or the wrist drop. And then comes the osteoporosis. Osteoporosis, as in seen in tamoxifen drug, the hormonal therapy, which is responsible for depletion of the calcium and resorption of the bone. And so in case if the patient is in hormonal therapy, start giving your resistance exercise or the weight bearing exercises to these type of patients. Then comes the radiotherapy related complications. These are the fibrosis. I have already discussed that it causes fibrosis or the tightness over the particular area जहाँ पे भी उसे radiotherapy दिया गया है. Then the pulmonary and cardiac problems. What happens whenever the you must have seen the radiotherapy machine, that is the linear accelerator machine. Patient is asked to lie in supine position with the hands over the head. And in this case, the linear accelerator machine, they used to rotate like 180, 360-degree rotation is there. And it covers all the areas of the axilla and the affected breast. So it not only affects it not only kills the cancerous cell over that area, but it also kills other structures present there. And what structure is present in the chest, apart from your breast, is your lungs and the heart. So the lungs will also going to get affected, and heart also. Heart gets affected mostly in patients with the CA breast of the left side. Why? Because the heart is situated in the left side. So it comes under the field of your radiotherapy, and it will going to cause your ischemic changes in the heart, and the patient will going to get ischemic heart disease in the later period of life. And in pulmonary complications, usually radiation-induced pneumonitis is the primary concern. The patient comes to us with a complaint of dyspnea and associated with pain and dry cough also. So if it is radiation-induced pneumonitis is present there, we have to check for the we have to check the 6-minute walk test also, so that the functional capacity of the patient can be tested, the inspiratory muscle strength can be checked, and the inspiratory muscle training is done in these type of patients. Then the neuropathy again, because of the involvement of the brachial plexus over the axilla, the radiation causes damage to the brachial plexus, and that will going to lead to neuropathy. Then is the physiotherapy role in cancer rehab. So the main aim of physiotherapy is to improve the quality of life of your patients, improve their functional capacity, and reduce the complication. So it is having a preventive role that is mainly instituted during your pre-operative phase or your pre-radiation phase, where you're going to tell what all complications will going to come after the radiotherapy or after the surgery, and how it can be prevented or it can be treated through physiotherapy. Then the restorative, whatever is there, you need to restore the thing. So you have to strengthen the muscles, you have to maintain the joint range of motions, because joint range is affected in CA breast patients after the surgery and after the radiotherapy. The patient usually complains of restricted shoulder joint movement. So you have that restorative function. Also, restorative function is done to prevent the occurrence of the lymphedema. Then comes the supportive. Supportive is usually done in case of like neuropathy, where there is a patient has developed brachial plexopathy or the wrist drop. Then supportive physiotherapy comes into action, and then the palliative physiotherapy, which is the last stage of patient's life. Here, our aim is to have a good quality, or to provide a good quality of life to that particular patient, to reduce her symptoms, her pain, and peaceful death. Means the patient is, we know that the patient is having not having much time. So whatever time is there, she could enjoy it with the family. She could have a good, happy, peaceful death with no regression at the end, that she has not spent her last phase of life with the family. So here palliative physiotherapy is very important, and along with physiotherapists, the psychologist and social workers and palliative pain and palliative physicians, they are having an important role. So basically what happens, onco rehabilitation is an umbrella where every professionals, they work together for the betterment of a person or to improve the quality of their life. General guidelines for physiotherapy. Whenever we start the physiotherapy, proper assessment has to be done, and all kind of physiotherapy needs to be done in under the supervision of a trained physiotherapist. Also see that the patient should not be having any kind of tight clothes around. That is, the range of any kind of joint should not be restricted. It should be free. And also the exercises should not be done in a fast, jerky manner. All the movements has to be done very slow and in a rhythmical manner. Some care has to be taken while dealing with the reconstructive patients who have undergone the reconstructive surgeries. Like, for example, we know that from the day one itself, in the post of day one, we start with the post-operative oncophysiotherapy, where we teach certain type of mobility, simple mobility exercises to the patients in ward, just to maintain the range of motion in your shoulder, in your elbow, and the wrist. So if the patient has undergone reconstructive surgery, then we should not allow the patient to abduct the hand beyond 90 degrees. That means overhead abduction or any overhead movement of the shoulder has to be restricted in these patients. And in other patients, like in case of breast conservative surgeries, in case of radical mastectomy, we can allow the patient to take her shoulder overhead. Even though drain is there, there will be chest drain. Patient will going to tell you, I am having chest drain, I am having pain, everything. You should not listen to the patient. Just assess the patient. Is there any kind of complications which is present, or your physiotherapy is contraindicated? Just look for that. If it is not contraindicated, it can be instituted safely. Just go with your mobility exercises. So I have already discussed this. Physiotherapy interventions are of three types: the pre-rehabilitation during acute phase and the chronic phase. Rehabilitation means your before surgery or before any kind of radiation, where breathing exercises has to be taught to the patients, then strengthening exercise or mobility exercises, every kind of education has to be given to the patient regarding the posture, regarding the lymphedema management, everything. During the acute phase,
Yes, ma'am.
yeah.
Sorry to intervene, ma'am.
Yes.
We have to wind it up, ma'am.
Okay, ma'am. 2 slides are there. Should I complete it?
Yes, ma'am. We have
Yeah.
to wind up in 5 minutes, ma'am. Sorry
Yeah.
to intervene, ma'am.
No, ma'am. 2 slides are there. Thank
Okay.
you.
Thank you, ma'am.
And during the chronic phase, strength training
Hello?
and cardiovascular fitness is done. So lymphedema management, it is the most common condition and usually remains underrated. You have to see for the, you just need to check whether the swelling is of lymphedema or it is of the, your general swelling. Go for testing of the steamer sign. Just pinch the base of the third metacarpal between your thumb and index finger and see whether you are able to lift it up or not. If you are able to lift it up, that means it is a simple swelling. And if you are finding difficulty in lifting or pinching the skin between the thumb and the index finger, that means it is a swelling, which is the lymphedema, and management has to be done. Complete decongestive therapy is given, where manual lymphatic drainage is done, which is a specialized kind of massage. And then the multi-layered limb bandaging. In the picture, you can see that the limb bandages are being done, and layer by layer bandages are wrapped in the patient's limb. And these bandages are actually short stretch bandages. These are not the stretchable bandages like that of your crepe bandage. And the pumping exercises has to be given. All your pumping overhead exercises you should tell your patients during your lymphedema management. And certain skin care and precautions have to be taught to the patients, not to get any kind of beanie puncture done in the affected part, not to get the blood pressure measurement done on over that area, and not to lie with the affected arm under your head like this. So these precautions has to be taken by the patients. Then comes the chemotherapy-induced neuropathy, where the patient complains of pain, tingling, and numbness over the part, and certain sensory exercises using of your textured mats, using of your textured devices like the cotton, the silk, then brush you can use, and different textures has to be given, first with the closed eye and then the open. This will help to retrain the brain. Then the strength training, because of the neuropathy, the patient might complain of weakness of the muscles. So strength training has to be instituted. Balance and gait training, particularly of the lower limb. The patient of CA breast, they come to us with the foot drop. And the TENS is the best choice of modality for your pain management. So we have seen that not only cancer is responsible for causing the physical dysfunction, but also the psychological impact also. Patients goes into depression, anxiety. So in this case, body image has to be improved, self-esteem has to be improved, and emotional well-being has to be given to the patient. So in this case, mindfulness activities is instituted, and stress management program like the yoga, meditation, music therapy, these are given to the patients. So we have seen that how physiotherapy has empowered the females with breast cancer by restoring the function and independence, by breaking the myths and fear, because they are in fear that if I'm going to do the exercises, then my at the incisional area, the incision will going to get break and things like that. So there has to be education regarding the breaking of the myths and fears of doing any kind of activity or exercises. And finally, the survivorship and long-term well-being, where we are actually responsible for improving the quality of life. So this was from my side. Thank you. I'm now open for the questions.
If anyone is having any kind of question, can ask to ma'am now.
Ma'am, questions are there in the chat box. There is a question about
Hello?
recent advances.
Hello?
Hello.
Hmm.
Yeah, ma'am, there is a question about latest research or evidence-based practice in physiotherapy for breast cancer patient.
Recent, pardon, ma'am.
Advances, ma'am.
Advances for breast cancer rehabilitation.
Yes, ma'am.
Okay. Yes, ma'am. So the recent advancement is like now, apart from the complete decongestive therapies, we have started using the other modalities also for reducing the lymphedema. For example, like the laser therapy is of utmost importance in these patients. If I having a laser therapy in your center, then you can go for it if the patient with lymphedema is there. Because earlier it was a myth like no modality is given to these type of patients, or all modalities are contraindicated in cancer, but it is not like that. Studies have been done and lasers are having a good effect on reduction of lymphedema. Apart from there, you can go for kinesio tape application also in case of lymphedema. For scar mobilization also, kinesio tape has given a good role, and only after scar mobilization we have seen a good impact on the reduction of the swelling.
Ma'am, the next question on the chat box is PCOS increases the risk of breast cancer. Does PCOS increases the risk of breast cancer?
Yes, yes. PCOS is a risk factor for developing the breast cancer. Because the patient is exposed to the estrogen level, large amount of your hormones. That's the reason why estrogen will going to proliferate or will going to favor the proliferation of these cells. It will affect the apoptosis or the removal or destruction of the cells. So the PCOS is at risk of developing, but not like always. See, PCOS has now become a very common condition nowadays, but it is not like all PCOS female will be having breast cancer. It is not. It is a risk factor. If already any kind of genetic changes is there, or any kind of family history is there, and the female has developed PCOS, then she will be at risk. So she has to take care of, like she has to have a good balanced diet and with proper lifestyle management. The patient, the female will keep herself away from getting any kind of breast cancer.
Thank you,
Yes, ma'am.
ma'am.
Any other
Am I?
question?
No, ma'am. There is no other question.
Thank you.
Am I audible, ma'am?
Yes, ma'am.
Okay. So thank you so much, ma'am, for the informative and knowledgeable session. As we have came to the end of this session, now I would like to deliver my vote of thanks. First and foremost, I would like to extend our sincere gratitude to our esteemed speaker for taking her time to share her valuable insights with us today. Your expertise and knowledge have truly made this session informative and enriching. We are incredibly grateful for the wisdom you have imparted and the engaging discussions you have sparked. A special thanks to all the participants for your active involvement and thoughtful questions. Your engagement is what truly made this webinar a great success, and we hope the knowledge shared today proves to be beneficial in our personal and professional journeys. I would like to thank our organizing team, IAP Utkal President Dr. Sthiti Pragya Dalabhera ma'am, and IAP Women's Cell Utkala Branch Coordinator Dr. Priyadarshini Mishra ma'am, for making this webinar possible, who ensure everything went smoothly with the support and guidance from our national team and IAP President Dr. Sanjeev Jha sir, IAP Women's Cell National Head Dr. Ruchi Vasini ma'am, and East Zone Head Dr. Smita Singh ma'am. And with that, I also thanks to our volunteers who help us to run this webinar smoothly. Thank you once again to everyone and have a wonderful day. Thank you, ma'am.
Thank you so much, ma'am.
To add on, I would like to thank IAP Digital team a lot for organizing this webinar, scheduling it on time. Thank you.
Thank you, ma'am.